Welcome. Thank you all again for being on. If you want to just throw in the chat sort of your name and where you're calling in from and your organizational affiliation if you have one, or just why you decided to sit in. I'd love to see that, get a sense of who's here. All right, so we're going to be talking today about Medicaid hospital finance. This is the third session of our Medicaid boot camp, or Medicaid night school, as someone recently called it to me. And we started with Medicaid in general. We talked about long-term care, and today we're going to talk about the role of Medicaid in shaping New York State's hospital system, and in particular in ensuring that there are hospitals to go to all across the state in every community, that hospitals don't close and so forth. This is you might think that just giving people Medicaid coverage would be enough, right? Like that. Since Medicaid, since they have insurance, they can go to a hospital, but they can't go to a hospital if there's no hospital there. And so we're going to talk about how Medicaid provides separate programs for safety net hospitals, how it funds them. But first, I want to just talk about what safety net hospitals are, and why they need so much financial support that it winds up being a huge part of the Medicaid program just to support them. So, for those who don't know, safety net hospital is like a loose term with a bunch of legal and specific definitions in specific contexts that generally means a hospital that is uh, considered necessary to provide its surrounding community with care, and that needs some financial support, usually from Medicaid and Medicare, in order to stay open. And so, the biggest reason why safety net hospitals exist, or why they're in the situation they're in today, is what I want to call the Great Rate Divergence. So this is like sort of the central story of U.S. healthcare history since 1990. I think we all uh, often have a picture of U.S. healthcare history that ends in 1965 with Medicare and Medicaid, or ends in the 70s when we failed to do the right thing and passed single payer. But there's been a lot of history since then, and one of the great themes of this history has been a huge divergence in payment rates between sort of the public half of the healthcare system and the private half of the healthcare system. So I talked a little bit about this in our first class, that private commercial payers in New York State now pay 2.5 times as much in terms of their prices. So, like, your employer's insurance pays 2.5 times as much as Medicare for every appendectomy, every ER visit that you encounter as someone with private insurance, versus what would be paid by Medicare fee for service, and Medicaid pays even less than Medicare. So there's a huge gap. This sort of captures the history here. It doesn't go all the way to the present. It ends in 2018, but you can see that basically as of 25 years ago, in the year 2000, private payers paid about 15% more than Medicare. And now it's more like it's almost double nationally and 2.5 times as much in New York. So an enormous gap. And I want to talk about a little bit about why that happened. So until the 1990s, Medicare, Medicaid, and private payers all paid pretty much around the same amount for hospital care. In New York, actually, rates were regulated by the state. So what every payer paid was just set by a state commission. and so prices were regulated, and they were also basically the same. Medicaid and Blue Cross paid, I think, a little bit less than private payers, but there was a set price. And nationally, that was generally the case, that whether rates were regulated or not, they were pretty close between private and public. Um, and then beginning in the 1990s, rates started to diverge, and they've just kept diverging. Private prices have been going up and up and up relative to Medicare and Medicaid prices. And really, the reason for that is that the public sector and the private sector engaged in two different cost control strategies. The private sector experimented with sort of managed care, market-based cost control. And what that looks like is every insurance company goes out and negotiates with every hospital system and says, I'll pay you 100 for an appendectomy. And the hospital says, no, I want 200. And they meet in the middle. And it's a negotiated process. And that's why your health plan has a provider network where you can only go to some hospitals and not others. The ones you can go to, the ones that are in network, are the ones where your insurance company settled a deal on service prices with that particular hospital. So that's one strategy. It's market-based. The idea is the managed care companies will compete to restrain costs, and then they'll compete with each other for the business of employers and private individuals, and that's going to hold down prices. Medicare and Medicaid, on the other hand, even though those programs have both experimented with managed care in other respects, on the question of like how provider prices are set, Medicare and Medicaid just set prices. Like Congress decides how much Medicare is going to pay, and then there's a commission to work out the details. The state legislature decides how much Medicaid is going to pay hospitals, and then there's an administrative state to work out the details. But basically, the prices are set. And what we've seen over time is that basically the public price setting regime has done an effective job of sort of holding prices down, whereas the private market-based regime has just expanded and expanded and expanded. So again, you see this really huge divergence between public and private payers over time. And again, I'm using Medicare as a proxy here because there's a lot of literature comparing it, but Medicaid tends to pay even less than Medicare. And this is sort of an interesting story because you might imagine that, the public sector, we're spending other people's money. We're not that focused on cost control, whereas the private sector, your employer is really concerned to save on healthcare costs, and they're trying to hold costs down and so forth. But that's not really what we see in the system. What we see is that actually the private sector is spending like a drunken sailor on healthcare, while the public sector is restraining cost growth. And so this huge rate divergence really structures the healthcare system, because what it means is that if you're a hospital and a patient walks through the door and needs an appendectomy, you're going to be paid for that appendectomy really varying amounts depending on what insurance that person has. So, if the appendectomy costs $1,000 when the patient is insured by Medicare, you'll be paid $2,500 if that person is privately insured, and maybe it'll be paid like $800 if that person is on Medicaid. And of course, for the 5%-ish of New Yorkers and 8%-ish of Americans who are uninsured, the hospital is legally obligated to provide at least emergency care, but it will be paid generally nothing for that care, or very, very little, because you can send a bill for $10,000 to an uninsured person, but if that person can't pay, they're not going to pay. So depending on how that patient is insured, you're paid a very different price. And for many hospitals that have what's called a good payer mix, meaning they have sort of an maybe 20% of their clientele is on Medicaid, 40% is on Medicare, 35% is private insurance, and 5% is uninsured, something like that. Well, they take the good with the bad. They're getting paid a lot by some and very little by others, but on average, they're getting a decent rate. Where things start to break down is for a hospital with a really high share of public, especially Medicaid, but also Medicare patients. So they don't have those juicy privately insured patients walking through the door. Their sort of blended overall revenue is going to be much, much lower than a hospital down the street with a better payer mix. But of course, they still have to buy the same equipment. They're still competing in the same labor market for doctors and nurses, et cetera. And so they will be sort of structurally and fundamentally financially unstable, right? Because they're just being paid a lot less to do the same or similar care. And so why would a hospital be in this situation where it's seeing mostly Medicaid and Medicare patients? Well, the biggest single reason probably is geography. If you're in a low income neighborhood, you're going to see a lot more Medicaid patients and a lot fewer commercially insured patients. Another reason is mission, right? So in many cities, including New York City, we have a great public hospital system that has a mission and a commitment to treat anyone who walks through the door, regardless of their ability to pay and what kind of insurance they have. And for that reason, a lot of low income people go to those mission driven hospitals and they see a disproportionate share of sort of low paying patients. And then sometimes there's an element of perceived quality and reputation where, it might be that some hospital, probably because it's underfunded, has a bad reputation. And so people with the sort of money and resources and know-how to seek care elsewhere uh, do seek care elsewhere. And then it's left with the patients who are left, who are lower income, less able to get out of the neighborhood, maybe. So those factors can lead a hospital to have really heavily public payer mix. And if they have heavy public payer mix, they are going to wind up earning less money for the same care. Um, I want to sort of add and clarify that like there are other sources of distress besides the great rate divergence I talked to. There are other reasons a hospital might be unable to sort of finance itself out of rates. One is service mix. So service mix means like sort of what share of different kinds of procedures and patients you're seeing. There are some services, including for whatever reason, labor and delivery, but also inpatient psychiatric care and sort of trauma care, like for victims of violence, that are in the US system just aren't paid very well by most payers. And so there's on top of the payer mix issues, there's a dynamic where like even Medicaid pays pretty well for like open heart surgery. So you can, as if you're a hospital that has sort of the prestige and resources to be providing a lot of open heart surgery, you're getting paid for that for that. But if you're delivering babies, mostly that's a less well paid service, and so you'll get paid less. Um, there's also been a systematic shift to outpatient care, and that you know rich hospitals with resources have done a good job of like sort of chasing the patients out the door, opening outpatient clinics and stuff like that. Poorer hospitals that can't compete in those markets are just sort of left with structurally lower demand, empty beds, and that can cause financial problems. Um, Another dynamic to think about is that safety net hospitals are often, they're not the best reputation and the best viewed hospitals in their area. And so they may actually, in addition to getting screwed on low Medicaid rates, they may also get paid the least by commercial insurance because commercial insurance companies will say, well, we don't really need you in our network. No one wants to go to your hospital, so we're not going to pay you a lot. And then, of course, there's just sort of mismanagement. Local, it can be hard to distinguish between mismanagement and chronic underfunding, but I want to acknowledge some, hospitals aren't run by geniuses in every case, and so there's some mismanagement in there too. So there are a lot of reasons, and I'm spending time on this because these debates about what is happening, why a given hospital is in financial distress, come up a lot around hospital closures and debates around hospital closures. The advocates who don't want the hospital to close will say, well, like it's underfunded because Medicaid rates are low, but it's like a really important hospital. Whereas maybe state regulators who do want to see it close will say, no, 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 we just don't need a hospital here because of the shift to outpatient care, or this hospital is just badly run and that's why it's in trouble and it really should close. And those arguments can get complicated in any specific instance of a hospital closure. But what I want to emphasize, though, is that safety net hospitals are like a structural feature of the US healthcare system in this situation where we have fragmented insurance and we have high private payment rates and low public payment rates. We're always going to have hospitals that are in financial distress because they serve a low income publicly insured clientele. And so you can say in any given case there might be nuances, but in the system as a whole we have a structurally sort of two-tier segregated healthcare system where the bottom tier is always going to be underfunded on the basis of rates. The other thing I want to say about that structure and just sort of think about um, offer a way to think about that structure is like we're going to spend the rest of the hour talking about all of the billions of dollars that New York State spends keeping safety net hospitals afloat in various ways, like the different financing structures that allow us to do that. And so we're going to be talking a lot about how the state subsidizes poor hospitals, but I want to emphasize that poor hospitals also subsidize rich hospitals because they're two sides of the same coin. In the US, where some patients pay more, if you're running a hospital that's a rich hospital, your incentive is going to be to find as many high-paying privately insured patients as possible, to negotiate your rates up, to do the sort of well-compensated kinds of care like open heart surgery and avoid doing the low-paid kinds of care like inpatient psychiatry. But we can't have a city or a state where every hospital does that. Someone needs to treat the publicly insured patients. Someone needs to offer inpatient psych and trauma care and so forth. And so the result of that is like the rich hospitals can selectively only treat the patients that are profitable to treat because the poor hospitals are there to sort of be the place where the unprofitable patients seek care. And so, one way to look at it is like NYU Langone made $1 billion last year, and Health and Hospitals lost $1 billion last year here in New York City. But NYU Langone could make $1 billion because Health and Hospitals was willing to take on the care that didn't pay well. And so this is, even though it looks fragmented, it really is a system, and it's a system that is sort of structurally segregated. And just to emphasize that, so this is a little bar graph of the distribution of New York hospitals by the share of revenue they get from Medicaid. And you can see it's pretty clustered around like 15% share of revenue for Medicaid. That doesn't mean 15% of patients. It's probably more like 25% of patients and 15% of revenue are coming from Medicaid in most hospitals, and most are clustered around that. But you can also see that there is a long tail to the right of hospitals that are seeing, 30, 40, 50, 60% of their revenue coming from Medicaid. And this, we had to exclude public hospitals from this graph for data quality reasons, but if we could have included them, you would see that even more. And so those hospitals off to the right in this graph are going to be the ones that are in a structural state of underfunding and financial distress. I want to just address one question that people often have about this situation. So it's weird to think about a hospital market where the price of the same appendectomy at the same hospital can vary by a factor of almost three, depending on whether the person getting the appendectomy is on Medicaid or on Aetna or Anthem insurance. And one thing that the hospital industry often says about this is like, look, these two things are related in the following way. The Medicaid and Medicare prices are just too low. We can't make ends meet on Medicaid and Medicare prices. And for that reason, we're forced to charge really high private prices to make up for the low Medicaid and Medicare prices. And so we're shifting costs from the public onto private payers. And this is like a powerful argument for the hospital industry to make because it says two things. It says, number one, you may be shocked that our private pay prices are extremely high and are driving up your insurance premiums, but it's not our fault. It's Medicaid and Medicare's fault. We're just sort of have no choice but to charge more because they pay too little. So it sort of excuses hospitals for high private pay prices. It also makes the case for raising public prices. Like the argument is if you paid us more on Medicaid, we could actually charge you less on commercial insurance. So it makes the case for more money to hospitals in two different ways, on the private and the public side. But there is just no evidence for this, and it is not true, is what I claim. And I'm saying this because it comes up all the time in lobbying meetings and everywhere else, and I want to emphasize it. If cost shifting were the dynamic, if like the reason that hospitals charge high prices is because Medicaid pays too little, then what you would expect, I think, is for the hospitals that are taking the most Medicaid patients to be forced to shift the most costs and to charge the highest private prices. But we ran the numbers, and what we see is the exact opposite. So this is a graph of the horizontal is Medicaid revenue. So it's the farther to the right you are, the more Medicaid a hospital is getting. And the vertical graph is their private pay prices. And you can see it's the opposite of the cost shifting story. The more Medicaid a hospital takes, actually, the lower private prices they get. And I would say the explanation is just sort of rich hospitals with mostly commercial clients are prestigious and they're highly consolidated. They're often local monopolies, and they're in a position to jack up private prices. And they do that because they want to charge the highest price they can get. Of course, in New York, they're all nonprofits, but we know, university administrators, for instance, don't hesitate to jack up tuition because they think my institution deserves it. I'm going to get what I can in the market. Whereas poor hospitals that take lots of Medicaid patients, like I said before, they have limited negotiating leverage with insurers and they're forced to take lower prices, not only from Medicaid, but also from insurers because of that lack of leverage. So it's sort of the opposite of the cost shifting strategy, or the cost shifting theory. The truth is, private price healthcare prices are high because healthcare markets are dysfunctional and inflationary. Public prices are low because public price setting works, and restrains costs, and that's an important dimension of the whole healthcare story in the U.S. Um, but I think a lot of people, when they find out this sort of amazing fact about the great rate divergence and the fact that some payers pay 2.5 times as much as other payers, they're like, okay, Michael, like, sure, cost shifting, whatever. But what is the right price? Like, if Medicare is charging $1,000 for an appendectomy or is paying that, and commercial insurance is paying $2,500, like, what does the appendectomy really cost? And, um, you know, gun to my head, if I had to give a number, I would say we can look at Maryland, which is a state that still has hospital price regulation and regulates all the hospital prices. In Maryland, all of the payers pay about 135% of Medicare. So, in other words, a lot more than Medicare pays in other states, but also a lot less than private insurance pays. So, the sort of right price is somewhere in the middle, a lot closer to Medicare than to commercial insurance prices. But it's also a tough question to answer because the question of like what it costs to do an appendectomy is extremely hard or impossible to answer. It depends, what your nurse staffing ratio is, how nice your facilities are, like how much you're paying for materials, how much administrative bloat, how many VPs of communications technology you're paying, seven-figure salaries, etc. There isn't there isn't some simple way to establish what the right cost is. Ultimately, the question is political, right? Like we know that in Maryland, they're happy with their hospital system and they set the price. But we don't know sort of what the objectively right price is until we decide sort of what kind of care we want to deliver and what our hospital network should be. So it's a complicated question. But anyway, we're a little off the path here. But I want to sort of zoom out and say the situation we're in, the situation in which Medicaid hospital finance is necessary, is a situation in which we have a structurally sort of bifurcated and segregated healthcare marketplace where public payers pay less, private payers pay more, and that means that hospitals that treat mostly low income, publicly insured people are sort of structurally underfunded, and they would all close unless Medicaid found a way to sort of give them more money outside the rates to keep them open. And I'm going to spend the next session is about how exactly Medicaid does that, the politics and history of it. But I want to actually just pause here and take questions about what we've said so far and whether it makes sense. And people can either use the hand raising tool or they can just put stuff in the chat. But don't raise your hand on camera because I won't see you. Um, wow. If anyone wants to just disagree with me about cost shifting, I'm also happy to just have an argument instead of a question.
Hi,
Okay.
Michael.
Yeah.
I have a question. This is sort of maybe too out in the weeds on policy stuff, but I'm curious if the shift that you mentioned to the outpatient care at private hospitals um, taking business away from the public hospitals, did the shift to ACOs after the ACA have like contribute to that?
That's a great question, and I don't have a good answer to that. I think there are technological and regulatory factors, and the I think the financing model you're talking about also probably has a role, but I am not sure.
Thanks.
But it's something to look into for sure. All right. Um, so let's talk about so what we've covered so far, right, is hospitals. Some hospitals are disadvantaged by many factors, but largely just by taking a lot of Medicaid payment and patients. And because Medicaid payments are low, Medicaid sort of service rates are low. Uh, because the service rates are low, and so these hospitals are underfunded. Um, and so to keep them open, the government needs to spend money. If it didn't spend money, all of these hospitals that are getting paid mostly for Medicaid patients would just close. And the way that states across the country and New York in particular do this and keep hospitals open is through a broad category, like an alphabet soup of different kinds of programs and acronyms and state federal partnerships that are called supplemental payments. So these are payments that are within Medicaid in the sense that they're Medicaid matched, but they are not just the Medicaid rate. They are an extra amount of money, either a block grant or like a rate add-on that hospitals are paid outside the regular Medicaid rates, and that are directed specifically at safety net hospitals. And supplemental payments are a huge, huge share of all of the Medicaid spending that gets directed to hospitals. The This is national data from MacPac, so this isn't New York, but it's every state in the country. But supplemental payments, you can see, account for 20% of all Medicaid spending on hospitals. And then managed care directed payments, which we're going to talk about, but which I would say are sort of the same thing as supplemental payments or close play the same role, account for another 19%. So we're talking about like almost half or almost 40% of all of the Medicaid money going to hospitals is going outside of regular reimbursement rates in the form of supplemental payments. And supplemental payments are also a huge deal in New York. This is a graph of from the executive budget of supplemental payments um, in New York State in the past 10 years. You can see it's grown a lot, and we're going to talk about all the color-coded images here, but you can see this adds up to $3.5 billion a year. And that actually doesn't even include some other supplemental payments we'll talk about. So we're talking in New York State alone, we're talking about $6 or $7 billion a year going to these supplemental payments. And it's a little bit of a weird set of policy choices because you could say, well, the fact that these hospitals are underfunded is down to Medicaid rates being low. If we want to spend some state money to make these hospitals better funded, why not just raise Medicaid rates? Like, why go outside the rates and have other supplemental payments when we could just pay the rates more? And um, basically, the answer is that that would be more expensive. All hospitals take Medicaid, and if we just raise the overall Medicaid rate, then all hospitals, both the safety nets and the non-safety nets, would get that money. But if we do supplemental payments outside the rates, we can specifically direct them to the safety net hospitals that need the money. So it's like we're paying low rates, and most hospitals get by on the low rates because they also take higher paying Medicare and commercially insured patients. But the ones that are mostly serving Medicaid, we can direct extra money at them to keep the doors open there. And the state has more control and discretion over supplemental payments. It can, make hospitals do things in exchange for them. So there are other reasons too. But the basic dynamic is like every state Medicaid system sort of faces a trade-off where you can hold your Medicaid base rates down really low, but if you do that, then your most high Medicaid hospitals will get more and more financially distressed. And so you will wind up having to put more and more money into supplemental payments to keep those hospitals open. And New, New York has moved in the direction of like sort of low rates and high supplemental payments. I think it would be fair to say over the past 15 years. And many other states have too. So, in other words, instead of just paying higher rates, we're going to pay low rates. We're going to direct supplemental payments outside the rates to safety net hospitals. Obviously, if we're going to do that, it is going to be a central concern of ours that those supplemental payments get the Medicaid match. We wouldn't want to be spending state money with no federal match on healthcare because we could get the federal match. We would be if we did this outside of Medicaid, then we wouldn't get the match and we'd be leaving money on the table. And so a huge concern in supplemental payment policy is what is the federal government willing to match in terms of supplemental payments? And CMS and the federal government broadly have always been a little bit suspicious of supplemental payments. Like they've always sort of had one eyebrow raised at states and been like, you want to do what? Why? Because for one thing, supplemental payments are not exactly sort of core Medicaid. They're not like a payment for a specific appendectomy. They're more like sort of spending to keep the state's healthcare infrastructure healthy. And so they're a little bit outside the sort of core of what everyone understands to be Medicaid. They also involve a lot of state discretion, right? Like if you just raise Medicaid rates, then the people making the choices about what hospitals to use are the patients. But if you're using a lot of supplemental payments, then the state is sort of deciding, oh, we need more supplemental payments because we don't want this particular hospital in this neighborhood to close, whereas that other hospital in that other neighborhood, we're willing to see it close. There's a lot of discretion, which makes CMS uncomfortable because there's a question of like, is the state going to make the right decisions? Are these hospitals worth keeping open, etc. And so as a result, supplemental payments are capped by the federal government. And a lot of state federal Medicaid politics happens around what the caps are, what level they are, and whether they are going to go up or down. So under the Biden administration, they went up, and under the Trump administration, they're coming down quite a bit. And so the supplemental payments are capped by the federal government. I want to emphasize if New York wants to write a check for $1 billion to some random hospital in New York is a sovereign state. It can totally do that. But what's capped is the federal match, right? So if we write that check for $1 billion, the federal government is only going to put in its own matched $1 billion if its rules are satisfied, and those rules can be restrictive. And so again, this is a site of a lot of conflict. And a lot of the conflict has historically was around two programs that are still around, but have become less important in recent years, arguably. But they were the original supplemental payments, so we're going to talk about them. The disproportionate share hospital program and the upper payment limit program. So the disproportionate share hospital program, aka DISH, which will be very familiar to New York healthcare activists because there's constantly a threat that the dish will be cut, and people are always talking about what health and hospitals will do if there's a dish cut. So this is that program. Um, Allows states to claim the federal match on hospitals that serve a disproportionate share of uninsured or Medicaid patients. Payments to any given hospital are capped at its uncompensated care costs. So, like the federal government will look and see, you treated this many uninsured patients and this many Medicaid patients, and we're gonna use a formula to say you can only get this much dish money. And then this program started in the early 80s, and states immediately rushed to spend a ton of money on dish. And that made Congress very uncomfortable. So Congress put its foot down in 1991 and said, okay, no more dish. You can't just keep growing dish at a zillion percent a year. But instead of totally eliminating dish, it capped each state's dish at the level that it was in 1991. So basically, the states that rushed the fastest during the 1980s to do a lot of dish spending got grandfathered into having a juicy, large dish allotment, whereas the states that had held back were permanently frozen out of the program. New York did a great job of rushing to do a lot of dish spending in the 80s, so it has a really big dish allotment of 2.4 billion. I think that's an old number. It's a little higher now. Out of a total federal dish pot of $16 billion. So we get like more than an eighth of the entire national dish, which is great. Um, but Congress never really loved dish, even so, and so when the and remember, it's a program that's supposed to pay basically for care for the uninsured. And so in 2010, when the Affordable Care Act was getting negotiated, one of the ways that Congress decided to sort of pay for the Affordable Care Act was to phase down DISH. So instead of $16 billion total, it would phase down over time to basically zero. And the argument under the ACA was like, look, the ACA has solved health insurance. There aren't going to be any uninsured people anymore. There isn't going to be any uncompensated care, so we won't need this huge pot of money to pay hospitals for providing uncompensated care. Obviously, uninsurance didn't go away, and neither did DISH. Even though Congress voted in 2010 to phase out DISH, it voted in 2012, 2014, 2016, 2018, 2019, 2020, 2023, and 2025 to kick the can on phasing down DISH. So every 2 years, basically, Congress comes back and says, we'll just do it for 2 more years. And so this is why in New York City, there's like a sort of cyclical, like, oh my God, DISH is about to be cut. No, wait, DISH hasn't been cut sort of dynamic to this. And, you know, I tell this story in such detail because so New York still has $2.4 billion of DISH spending authority. And one way to look at it is that because of activism, Congress never went through with its original intention. Another way to look at it, and this happens a lot in federal healthcare policy, is that Congress was, during the ACA fight, was passing a reconciliation bill. So it needed to get a certain level of CBO scored savings to pay for the ACA. And during that reconciliation fight, it was great to be able to save $16 billion and then spend them on the ACA. But once that reconciliation fight was over, why are we cutting DISH now? Like, we've already spent the money on the ACA. The ACA is happening. Let's just keep DISH around. And that's something to think about as we live in the aftermath of Trump's reconciliation bill Medicaid cuts. Like they needed those cuts in order to get a CBO score, but there's an open question of like whether Congress will remain committed to those cuts as time goes on, or whether some of them that have been deferred for a couple of years might just be deferred the way Dish has. So Dish is one kind of traditional supplemental payment. Upper payment limit payments are another big kind of supplemental payment in traditional Medicaid finance. The upper payment limit, Congress didn't write a bill saying you can do supplemental payments, and we're going to call them the upper payment limit. What Congress did was it said state Medicaid programs, you can only pay up to the Medicare rate. You can't pay any higher than the Medicare rate. We don't want you to pay more. And then state said, okay, so that's the upper payment limit. Well, for our safety net hospitals, we're going to spend all the way up to the upper payment limit. So we're going to have Medicaid rates that are way below Medicare. But for our safety net hospitals where we want to give them some supplemental money, we're going to direct UPL payments all the way up to the limit. So that's what UPL payments are. They've been around forever and are still around in New York and have been a major source of funding for public hospitals and private safety net hospitals. The thing about upper payment limit payments is that they only work within fee-for-service Medicaid. And you all know from class number one that most Medicaid in New York is managed care Medicaid. And so the upper payment limit is a limit for all of the fee-for-service hospital care that New York pays for, but not for any of the much larger share of managed care stuff. And so for that reason, we've had to replace UPL over time with a separate program called DPT, which I will talk about in a minute. But first, I want to sort of wrap what we were talking about with Dish and UPL and bring it back home to New York. So it's important to remember that Dish and UPL are not like sources of funding that Congress is giving the states. Rather, they're like spending authorities that a state can get its own money Medicaid matched up to the upper payment limit or up to the Dish allotment as the case may be. But when we say that New York has $2.4 billion of Dish authority, it's not like there's some federal budget item of $2.4 billion coming our way. What it means is that if we come up with $1.2 billion from tax revenue or whatever, the state will match it with $1.2 billion. And if we tried to spend above that under Dish, it would no longer be matched. And so New York has this authority. It has to spend into the authority with programs. And traditionally, New York has funded a lot of the supplemental payments through something called the Indigent Care Pool, or ICP, which is funded by a tax on healthcare providers and health insurance. And the original intent was to compensate hospitals for uninsured, aka indigent care. So the idea was like, we're going to tax all hospitals, put all of the money in a pool, and then use the pool to pay money out to the hospitals that see the most uninsured, which is a good model. Unfortunately, the actual formula for distribution is still now and was always historically like kind of biased in a way where it wound up giving money not just to the safety net hospitals, but to every hospital based on its own political power. So there was stuff to critique about that, but the pool still exists and it still redistributes around $1.1 billion across various providers, across safety net and non-safety net hospitals. I'm not going to go through in detail every one of these payments, but just to sort of emphasize the dynamic here. This is a screenshot from New York's states, like state plan amendment for hospital supplemental payments. So this is our application to the state government or to the federal government to say, here's what we're planning to do with supplemental payments. And you can see there are a bunch of lines here totaling $3.4 billion in gross spending. And you can sort of trace them and say, like, okay, so the indigent care pool slash voluntary UPL $339 million guarantee, which is sort of generating a $825 million. The money is from the indigent care pool, and then it's being spent under upper payment limit federal authority. So you can see the sort of dynamic where the state comes up with the money, and then it applies to the federal government and says, we're under the upper payment limit. We can use this funding to sort of fill up our upper payment limit. And similarly with all these other programs. So these DISH and UPL are still around and still fund a bunch of state-owned hospitals, public hospitals, private safety net hospitals. But actually, even though they're still pumping out $3.4 billion of safety net funding, they are no longer the largest and most important hospital safety net funding mechanisms in New York, because we have a number of other programs, and so that have increased rapidly in the past several years. And so this graph lays out these new programs. It's from the executive budget briefing for this fiscal year. And what it shows is the colorful bars are many different supplemental payment programs that we're using. You can see the biggest one is the dark blue one, which is DPT funding. There are 8 other acronyms on this. And you can see that we're spending through these programs, $3.5 billion a year on about 75 financially distressed hospitals statewide. So that's about a third of the hospitals in the state. And so why all these new programs? There are 3 dynamics. One is just there's been growing need among hospitals, and and Medicaid base payment rates were basically flat for a decade after 2011. And so, like I said at the beginning of the call, right, like the lower you keep the base payment, the more supplemental payment you're going to need. There's also a big post-COVID sort of shift in the hospital industry. And then there's the shift to managed care, which limits the use of upper payment limit, the upper payment limit mechanism, and has required us to switch to state-directed payment or DPT authority. So these dynamics cause these new programs I'm about to talk about. And just listing off the acronyms, we have directed payment template or state-directed payment funding, which is counting federal match is about $4 billion a year right now and is about to be cut by H.R. 1 in a way we'll talk about. We have VAPAP, the Vital Access Provider Assistance Program, which is $1.3 billion. We have the Hospital Global Budget Initiative, $500 million. Vital Access Program, VAP, not to be confused with VAPAP, $300, and we have Safety Net Transformation, another $300. So all told, we're talking about, many billions of dollars, $6 billion just in these new programs on an all funds basis. So I want to just run through quickly what the biggest and most important of these programs are. Starting with DPT funding, because it's by far the largest. It's $4 billion all funds per year. So directed payment template funding, basically the history here is we used to have upper payment limit payments. they allowed states to top up safety net hospitals' Medicaid rate up to the Medicare rate, but they only worked for fee for service. So you could only top up the rate if the patient whose rate was being topped up was a fee for service patient. And and so if you move to managed care, then for the patients you are covering under managed care, you could no longer sort of top up the payment. So that would be a problem for your safety net hospital spending. And so the federal government, the story is complicated here, but during the Obama and Bush administrations, over time, the federal government codified a way for states to essentially do a UPL-like thing, i.e., pay higher rates to safety net hospitals, but under a managed care system. And these are called state-directed payments, and they're called that because the state is directing the Medicaid managed care company to pay more to specific hospitals. And and so like New York State can say, with all its Medicaid MCOs, it can go to Centene and to Aetna and to Health First, and it can say, look, we're setting the overall hospital rate at $2,000, but when you have a patient who goes to Wyckoff or Maimonides or Health and Hospitals or another safety net hospital, we want you to pay them more, a higher rate. We want you to pay them like $3,000 instead of $2,000. And originally there was an upper limit on this that was up to the Medicare level of payment. So basically the MCOs could be directed to pay up to Medicare rates. But then the Biden administration really did a very nice thing for state governments and safety net hospitals by actually saying, no, the Medicare rate is too low. Rates have diverged too much. We're going to allow state-directed payments to go all the way up to commercial rates. So we're going to let states pay Medicaid rates specifically to safety net hospitals that are as high as private pay rates. So that created this huge new opportunity for safety net funding, which New York immediately took advantage of by moving a huge amount of money into state-directed payments, and now up to $4 billion a year. Health and hospitals alone gets a huge share of that, like 2 billion-ish. And so it's become very quickly a really important mechanism for this stuff. But unfortunately, the Trump administration, as part of the One Big Beautiful Bill Act, decided that no, that's too high. We're going to actually put the cap back down to Medicare rates, phasing in over time starting in calendar year 2028. And so what that effectively means is it's a rate cut to every safety net hospital in New York, and especially a rate cut to New York City Health and Hospitals. So it's going to be a big pressure point for the Medicaid system in New York State in the next 3 or 4 years as those cuts phase in. Unless the DPT thing or the DISH thing happens, where Congress next year decides that it actually doesn't want to see these cuts phase in and kicks the can for 2 years and then does that every 2 years for the rest of the decade, which is what we should all be hoping for, because it will be a really serious cut. But that's what DPT funding is. Again, that's the big dark blue line in this graph. VAPAP, the Vital Access Provider Assistance Program, is more of an emergency funding program for hospitals that are really about to kick the bucket and about to miss payroll and need constant big checks from the state to keep open. If your local hospital is receiving VAPAP funding, you should worry that it is in really serious trouble. VAPAP is much more ad hoc and less structural than DPT. The governor threatens to cut it every year. And it's not really Medicaid matched, or it's only Medicaid matched via a temporary waiver. And so this isn't funding that we should count on in the long term. Um, and there's another program called Vital Access Program, which is similar but smaller and mostly for rural hospitals and a little bit more stable. The Hospital Global Budget Initiative is another 500 million for downstate private safety net hospitals. This is closely related to the 1115 waiver, so I'm just including it here for completeness, and we will talk about it next week. I think it's really cool. And then the final pot of funding is called the Safety Net Transformation Program funding. And it's $300 million in operating support that's associated with capital funding for hospitals for a special group of hospitals that the state DOH sort of decides are on a path to transforming themselves into financially viable hospitals that don't need state support. So the safety net transformation program is interesting because it speaks to the sort of the politics of hospital closures in New York. State the state government, like the executive branch, the Department of Health and the Department of Budget, do not like this graph at all. They look at this graph of dramatically rising supplemental funding and 70 hospitals needing supplemental funding, and they say, too much. We don't like this. Something has to change. These hospitals can't just keep losing a zillion dollars every year and the state making them whole. But it is incredibly, incredibly politically difficult to close a hospital because local communities really, really hate the local hospital closing. Uh, Hospitals are major employers in their communities. People worry about, if I have a heart attack tomorrow, what's the closest ER? And so, um, and so there's a dynamic where from the state government's perspective, some safety net hospitals are just, they're mission driven. They're always going to lose money. We're willing to continue to fund them indefinitely. Other hospitals, state DOH and DOB looks at them and is like, man, that hospital sucks. Like, if that hospital closed tomorrow, I wouldn't shed a tear. It's half empty. It's poorly managed. We don't need a hospital there anymore because of the shift to outpatient care. They're just waiting for them to die. But in the meantime, we're spending billions of dollars to keep them open because it's politically challenging to close a hospital. And then there's maybe a sort of a third group of hospitals where the state might think that hospital in its current form doesn't make any sense. Like, it should close. But we can imagine that if that little private safety net hospital teamed up with a big system that was sort of better at running things and had a better medical record system, and maybe it closed half of its beds at its current location and started sending patients to that larger hospital system, if it transformed itself, then maybe it could be a financially viable hospital that we could stop supporting because it could, walk on its own 2 feet, or it could be the problem of a larger partner hospital. And the safety net transformation program is sort of funding that is designed to encourage that kind of transition and represents sort of the state trying to say, what is the future of these hospitals that isn't the difficult to swallow political pill of closing them and isn't the difficult to swallow budgetary pill of keeping them open. So that's that pot of money. And these are so in the aggregate, we're talking about many billions of dollars. We're talking about like a Medicaid program where Medicaid rates are not high enough to keep hospitals open by themselves. And so we spend probably a third of the money that we spend as a state in total on hospital care through Medicaid flows not through those hospital rates, but through a variety of Medicaid supplemental payments. Those payments have gone up a lot in recent years. Many hospitals need them to stay open. And the future of this system is really ambiguous. I think there is little prospect of solving the problems of segregation and rate divergence and so forth that cause safety net hospitals to need funding. There is a perspective that these supplemental payments are just what it takes to maintain an adequate hospital network in New York State. And there really isn't a problem here that we're spending so much on supplemental payments. This is how we're deciding where hospitals stay open and which communities need hospitals. It's a political decision. We're going to keep doing it. There's another perspective that's like, these hospitals, we don't need them. There's been a shift to outpatient care. They're poorly run. And we're not going to close them all tomorrow because people would freak out. But someday there's going to be a recession and tax revenue is going to shrink, and there will be a crisis opportunity to close, 10 or 20 hospitals across the state and get local communities and politicians to bite the bullet. And so those are sort of, I think, the two futures, like the future as envisioned by healthcare advocates and the future as envisioned by the State Department of Budget. And it will be really interesting to watch that dynamic play out in state budget debates over the next couple of years, especially as these Medicaid cuts start to pinch and make money a little bit tighter. Um, I'm sorry, that was like a lot of acronyms to cover, and I hope it didn't drown out the conceptual points. I have one more topic to cover, which is provider taxes. But I want to pause here for questions about safety net hospital finance. Leah.
Hi, Michael. I'm curious what your prediction is if you had to predict how it's going to go with the budget cuts. You outlined a few different paths that hospital closures might flow upon, and I'm curious, if pressed, what you think might happen.
Um, I think that if there's a huge recession, then all bets are off, is what I would say, right? Like if there's a huge recession, there are major cuts. I could see a lot of closures happening. I think that if that doesn't happen, it is likely that we will just sort of continue as we are. I think there is a tendency among especially like bean counter sort of non-healthcare specialist like budget people and wonks to be to see supplemental payments as like an accidental feature of the system. Like ideally, hospitals would just get by on rates. That's what makes sense. And then there's this sort of bug or this asterisk or this Rube Goldberg machine used to like support hospitals that can't do that for some reason, probably because no one wants them there and no one wants to go there. But I think that perspective is wrong. Like as I said, like the deep logic of our healthcare system really really sort of determines that there will always be these sort of underfunded safety net hospitals, and so and so there isn't like there isn't a way out of this other than ending the great rate divergence and reconverging rates. I think I am really, really interested in and frankly excited about one recent development, which is the Health and Hospitals takeover of or merger with Maimonides Hospital in Brooklyn. Maimonides is one of these hospitals that's like absolutely vital to its community. It's unimaginable what would happen if it closed. It, delivers more babies than any hospital in Brooklyn. And because its local community is high Medicaid and because it does so much labor and delivery and so few open heart surgeries, it's never gonna turn a profit. And so it was for years this sort of like private safety net hospital that lost $1 zillion a year and the state plugged its gaps. And now it's merging with the public hospital system. And from my perspective, that makes a ton of sense. If we're going to have hospitals that are basically being kept open with public money, then they should be public hospitals. And like we shouldn't have this sort of fragmented system of half a dozen little private safety nets. We should have one big public hospital system. So I think that's a policy direction I would like to see us see more of, and I was excited to see it happen. And I'm also really excited about the global hospital budget initiative, but we'll talk about that next week because I couldn't quite get there. Other questions? If not, I will move on to talking about one of the dumbest and craziest things about Medicaid that I personally know. Okay. So the next topic, which belongs in this session because it's a financing mechanism that is often used to fund supplemental payments to providers, is something called a provider tax. And so, the state, when it wants to raise Medicaid revenue, when it wants to raise Medicaid spending, it has to spend some money, which it gets through taxes. So we pay income taxes and sales taxes, and they go to fund the state share of Medicaid. One thing that a state could decide to tax is healthcare providers. So it could say, we're going to finance Medicaid by taxing hospitals. And if it does that, there is a really, really cool trick it can pull that essentially generates federal Medicaid matching funds without costing the state anything. This is called a provider tax, and it's I would say it's a trick states use to generate more federal Medicaid revenue, but I think federal Medicaid revenue is good, so I think it's a good trick. And I also think it's very clever. So if you have sort of an aesthetic appreciation for it, you might enjoy. I'm going to walk through like a very simple version of a provider tax. This literal thing is illegal. Like you can't actually do quite this thing, but this is sort of the Platonic ideal of a provider tax. And then I'll talk about how federal regulations affect that and how it gets more complicated. But the basic structure of a provider tax, a Medicaid provider tax, is like, let's say you go to your local hospital and you say, all right, we need to raise money for Medicaid. We're going to tax you $100. So the hospital gives the state $100. Then the state spends $50 back into the hospital, like paying for appendectomies or whatever under Medicaid. And because the state has spent $50 in a way that's Medicaid matched, the federal government will supplement that with another $50, right? And so the hospital paid $100 in taxes. It got back $100. So it is now like just as happy as it was before. It effectively didn't pay any tax. On the other hand, the state got $100 in taxes, but it only spent $50 paying back the hospital. So the state is up $50 from the federal government. right? So what the state did was it took $100, it paid back $50 with the federal match, that was $100. Now it's still holding another $50, which if it then spends that other $50 on Medicaid, then it can get another $50 in federal match. So effectively what happened is that uh, the state generated $100 of new federal Medicaid match without anyone in the state paying a net tax, right? Because the taxpayer is the hospital, but the hospital is getting paid back. And so this mechanism could potentially allow, like, again, there's now regulation that limits how useful it is, but it could, in principle, in this pure form, allow the state to generate an infinite amount of Medicaid match, right? Like it could, why tax the hospital $100? Why not tax it $1 million and then generate $1 million of new federal Medicaid spending? So this is what a provider tax is. It's like a wormhole in Medicaid rules that allows the state to increase federal reimbursement without spending more. And because it is a wormhole, whatever friggin' genius in a state Medicaid office in the early 80s figured this out, every state immediately copied them, and there were a whole bunch of Medicaid provider taxes. In some instances, states would actually like use this structure to like not to generate more money for Medicaid, but just to like fix highways or whatever, right? Like they would say instead of spending Medicaid money to get federal match, we're going to just tax providers, spend it back. The providers are whole, and then we have another $50 to go repair highways. And so all of that, it was all too good to be true. And in the early 90s, the federal government regulated it, but didn't eliminate it, right? So the federal government said, okay, what you can't do is you can't go to like some individual hospital and make this deal with it. If you want to have a provider tax, you have to tax all hospitals, and you also can't guarantee any of the hospitals that they'll get all of their money back. So like if you want to do this tax, you have to tax both the rich and the poor hospitals that are high Medicaid and low Medicaid, and you have to sort of some of them have to pay a net tax unless you keep it within reason. If you're under 6% of total provider revenue, then you can do whatever you want. So basically, it's a little bit like the dish story, right? Like that Congress saw that states were going too far, stepped in, regulated, but because it couldn't put the genie all the way back in the bottle, it just sort of kept a limit on how far out the genie was. And New York has um, New York has a few different provider taxes. New York's HICRA tax, which funds the indigent care pool and is complained about by conservatives in New York a lot, is a provider tax. It's a tax on hospitals that goes to fund Medicaid, but it's actually carved out of federal regulations because we had a really powerful Republican senator in the early 90s who got it specifically carved out. So there's like a line in the federal law that says any tax that was in place in New York before 1992 is not subject to federal regulations. So that's nice for us. We also did a gigantic version of this called the MCO tax to generate a whole bunch of money in the past 2 years. We generated $3.4 billion of net federal revenue without anyone in New York having to pay more taxes by taxing Medicaid managed care companies and then paying them back with Medicaid matched funds, and we use that money to increase hospital rates. And that's often the dynamic with provider taxes, is that it's often the provider's idea, and they'll go to the state and be like, hey, we talked to a really smart Medicaid consultant. We have a great way for you to increase Medicaid rates or increase supplemental payments without paying higher taxes. Here's how to do it. and that's why I'm including them in this section, is that provider taxes often go to fund supplemental payments or hospital rates. Again, I think this is like conceivably too clever by half, but also basically just a way to get the federal government to spend more on Medicaid, which I support. Unfortunately, Donald Trump does not support that. So HR1 really heavily restricted provider taxes and in particular got rid of New York's MCO tax, which was generating $3.4 billion over 2 years, so $1.7 billion a year, that we're now going to have to find some other way to make up in order to keep the Medicaid rate increases that we generated. So Medicaid finance has become both more austere and less fun than it was before. But anyway, I just wanted to cover that because I get a lot of questions about it. And with that, I think we've covered what I wanted to cover this evening. Any questions? Okay, I have a question for you all, which is next week is our last class, and I'm going to spend some of it talking about the 1115 waiver, which is relates to hospital finance, but also health equity and social determinants of health, and also managed care, and is in the news right now because it's up for renewal. So it's going to be a site of conflict between the state and the federal government. That's the like content I want to cover, but I could do that. I don't think that will fill the full hour and a half. And so my question to you all is, what is something you would like to see covered or talked about next week that I haven't talked about or haven't talked about enough yet?